Okay, now welcome everybody. Welcome back to Best of the American College of Rheumatology 2021 Convergence meeting brought to you by CornerStones. Now, probably most people have already had the introduction, so I'm going to go fairly quickly last night that David gave. But as you're aware, this is a program that we've put together to really bring you the best of the ACR program. First, we'd like to acknowledge country. I'd like to acknowledge the Bunurong Boonwurrung people who are the traditional custodians of this land. We'd like to pay respect to the elders past, present and emerging of the Kulin Nation and extend that respect to other Indigenous Australians present and to the First Nations people of the land that you are currently on. So just very briefly, we put this program together over the last few years from the ACR with a steering committee that tries to bring you the optimum abstracts, the optimum presentations from the ACR. There's a wealth of information. It's hard to assimilate, and we've spent a lot of time and hours trying to synthesize what we feel is important data for you in your clinical practice. We'd certainly like to very much thank Janssen for funding this program, but they were very much hands-off and we had free rein to choose what we wished from the conference. So as people quickly, just very aware, we get the abstracts, we got the program, we went through it fairly extensively. We narrowed it down to 80 abstracts. We then narrowed that down further to around 35 to 40 key abstracts from the conference, and now have it in a hopefully digestible form that will be beautifully presented by my colleagues David and Rebecca tonight, part of the faculty. And here is the team: Rebecca Granger, Helen Keane, David Liu, Erwin Lim, Pallavi Shamdasani, a registrar who did a fabulous job in helping us to put it together, and myself, Andrew Oster.
So there was a lot of lupus at the meeting. We sifted through all the abstracts, and in many cases in the slides I'm going to present, we actually took 2 or 3 abstracts that had related topics or overlying themes and have combined them together for something for you to take away. So we all see patients with lupus in our clinics, and there are problems that they talk to us about that we sometimes not really quite sure how to address in that 15-minute follow-up clinic. And fatigue is one, and that brain fog, the cognitive symptoms in lupus. So the ACR has very helpfully, in a paper from 1997 from memory, established a cognitive battery. Now, do not be alarmed if you're not familiar with said battery. It has 6 demands. The different tests sounded quite complicated. I'm not sure now that 9:36 at night I would pass myself, but it takes about an hour to do. And so really it's reserved for either research purposes or in a specialised clinic. So, but actually cognitive dysfunction may affect up to 40% of people with lupus, which makes it actually common. And this neuropsychological battery is not practical. So there's a couple of important questions that these data address. First, in lupus, do the symptoms our patients tell us about actually predict poor cognitive performance? So can we just take them at face value? And the second thing is there something we can do to easily screen for cognitive impairment so we can send people off for further assessment and then appropriate management? So there were 2 cohorts that both explored the relationship between reported cognitive symptoms and actually cognitive performance, and particularly also looked at what else predicted cognitive performance. So one cohort from the Monash Lupus Centre that had about a bit more than 90 people in it. You'll see in the next slide they have a slightly different sample size for the MOCA. For the MOCA they have a slightly different sample size, but it's the same cohort. And then a rather larger cohort from the Toronto lupus study. And then all these people were assessed with the neuropsychiatric battery, and then had different standard clinical screening tests with some overlap between the 2 cohorts, but some were only done in one or the other. Some of the screening tests included tests for central sensitization, so fibromyalgia, fatigue, function, depression, anxiety. And in Toronto, they also deployed a well-validated questionnaire which assesses for perceived cognitive deficits, the PD20. So when you look at the results in that green sort of table there, you can see that there actually was no difference between the people with lupus who had impaired cognitive function on the robust neuropsychological battery and those that were unimpaired. So first of all, the reported symptoms don't correlate with the people who are actually impaired, even when the cognitive dysfunction is quite severe. And in the Melbourne cohort, central sensitivity, anxiety and depression associated with reports of poor cognitive symptoms, and no association of cognitive symptoms with the cognitive results. And additionally, and similarly, the Toronto cohort, the perceived deficits associated with being female, fatigue scores, SF36 social role, and depression and anxiety score, and use of glucocorticoids, but not the neuropsychiatric, correlated with the neuropsychiatric battery, but not with reported symptoms. So that leaves us not really being able to rely on reported symptoms as being correlated with objective evidence of cognitive impairment. And that's when the MOCA comes in. Now, I'm getting old enough that the MOCA didn't exist when I was a medical student or a medical registrar, but in fact now it's the preferred and recommended test for cognitive screening in the elderly in New Zealand and Australia. It's relatively simple to deploy, but you do need a little bit of preliminary training. And the Melbourne cohort, the Melbourne group, Monash group, used the MOCA with different cut-offs to see which cut-off would predict poor performance on the neuropsychological battery. And in fact, a MOCA of less than 28, I think the top score's 30 from memory, had a pretty good sensitivity and possibly acceptable specificity and a pretty good area under the curve for predicting poor performance on the full neuropsychological battery, suggesting that the MOCA might be a valid screening test. Another group from the US used a computer test, so you didn't need a human, a clinician, to deploy the testing in the clinic. You could send the patients off to the computer test, and this performed reasonably well as well. So I think the take home here is that the cognitive symptom burden that people with SLE report is not necessarily associated with an actual objective cognitive impairment. And actually, if patients are reporting a lot of cognitive symptoms, we should assess for fibromyalgia, anxiety and depression, sleep. So there are things we can do, it's not to do with the lupus. And in addition, time permitting, the use of MOCA in a score less than and a score greater than 28, meaning probably don't need to do anything more, but a score of less than 28 may suggest going on for further formal assessment of cognitive function. So hopefully there's some things you can take away there for your practice.
Thanks, Rebecca. I was going to just quickly interject and say it's the ones that don't complain are the ones that we should be worried about.
Well, yeah, that's an interesting, interesting point, actually. Yes, you're quite right.
From this David?
Oh, no, I was going to say, I mean, Rebecca, it does always seem that we've never been good in the past at trying to pick up neuropsychiatric or neuropsychological deficits in lupus patients. But at the same time, these are often young patients who really need this. I mean, did this kind of stuff make you reflect on your practice? I know it certainly made me think about it, and the patients who don't complain are often the ones who are hiding this kind of burden this burden from lupus. Yeah.
I think the other thing that occurs to me is we meet our patients initially when they're sick. Usually, the first diagnosis of lupus, they're not well and they're in an unfamiliar environment often, and we only get to know them through relatively infrequent visits. So I'm not sure that we've got the sort of barometer or the set point to really appreciate what a change in cognitive function might be for that person. I wonder a little bit about corroborative history from other family members, or also reflecting if people have major changes, for example, in their employment. You know, maybe that's another clue that we should be looking for some of these things. But interesting to provoke a little bit more thought about this in our clinic, and particularly treatable things like anxiety and depression. You know, we're talking therapies or other cognitive behavioural therapy, or perhaps pharmacological management might be quite an easy fix, or quite, you know, quite accessible.
I mean, we saw a lot of the meeting about fatigue, and this, I guess, this kind of it kind of ties into it. It's the same type of things that we really need to target, and we need to get better at targeting, right? The things we're not doing well in practice.
Right. I think next slide, David. Okay, well, hydroxychloroquine dosing. 2016, American Academy of Ophthalmology guidelines, a big line in the sand there, folks. Came out very strong with data to back it up, that a dose of over 5 milligrams per kilogram of hydroxychloroquine was associated with a long-term risk of retinal toxicity. So some people have changed practice to dose reduce or modify the dose dependent on the body weight of their patients. Is there an association between hydroxychloroquine dose and lupus flare? Now, there are old data that do inform this, but I thought this was a pretty nifty study. This was from Boston cohort, 3 of the major hospitals across Boston, Mass General, Brigham and Women's, and a third hospital in that network. And they use a nested crossover study design where essentially the patient acts as their own control. And they were looking at the dose of hydroxychloroquine in the 6 months leading up to the lupus flare and comparing that with the control period the 6 months before. Over 4 years, they had almost 350 patients. And really, they were looking at what is the dose that people are on when they flare. Now, in the table on the bottom right there were sort of 3 tranches of data. The top one is all comers. The middle tranche of data are the people under 80 kgs. Now, 5 milligrams per kg, 400 milligrams a day, 80 kgs. So this is probably not going to be such a big problem if you are a lower body mass, but we know that we've got a bigger population. So body weight less than 80 kgs, and then the bottom tranche is the body weight more than 80 kgs. So we would be thinking that those are the people where the risk might be. So if we do look at all comers, where the high dose, 400 milligrams a day, was the reference, a low dose of less than 400 milligrams a day saw a numerically saw an adjusted odds ratio for flare of 2.38, which was significant. Not so much difference in the all-comers group for the moderate and lowest dose, but wait till you look at the weight-based categorization. So there was a risk with lower doses in the people less than 80 kgs, but go down to the people more than 80 kgs, where the moderate or low dose have got a very high risk of flare with the lower doses. So what this tells us is that lower dose, higher flare rate. What does this mean in practice? Well, this is where the art of rheumatology comes in, because we've got 2 problems here. Do you want short term, over the next 1 to 2 years, risk of flares versus a long-term risk of retinal toxicity? The risk associated with flares will be the impact on your health and well-being, but in addition, the burden of further therapy, particularly glucocorticoid, versus the long-term risk, which is somewhat is higher with more than 5 milligrams per kg. Other factors, renal impairment, tamoxifen use, etc. And really, a couple of things here. First of all, check the adherence, because there's plenty of data that says that people are not often adherent with the dose that's prescribed. So before we start titrating, let's check they're actually taking it. and then tailor the dose with shared decision making for the patient. Now, maybe if people have milder skin and joint lupus and they need a short period of glucocorticoids and then they're back in good control, maybe those people, we don't need to rack the dose of hydroxychloroquine up really high. But if we've got major internal organ involvement with those lupus flares, maybe we have to weigh that up against the long-term risk for retinal disease. But actually, that's quite individualized. I also thought when I saw these this abstract about what the arrangements are for retinal screening in different parts of New Zealand and Australia, our ophthalmologists take it in their stride, and in fact often have quite a lot of the screening done not by the ophthalmologist but by specialised nurses in the clinic, and also increasing use of OCT to pick up early changes. So the processes around retinal screening are getting better and better as well. So shared decision making. David, what did you think of this abstract?
Well, yeah, and I wonder what you think. And I mean, like, it rings so true what you said about the art of it. And clearly, a 5 milligram per kilogram just blanket rule is perhaps not. And I don't know if we've ever applied that in a blanket way in practice. I mean, what's in the guidelines doesn't always dictate what we do in clinic. I guess I wonder, in amongst it all, where drug levels sit. I know we've heard a lot from Michelle Petrie over time about the role of drug level and how that might reflect in terms of retinopathy. That's something that might become more available soon. I know that, I guess, in the past as well, like I say, there's maybe the actual detection of retinopathy may have limited our study in general of how therapeutic drug monitoring might have performed. You know, OCT now is clearly, it's become the standard of care, looking especially in risk groups that paracentral, not just that central area as well. Yeah, what do you think about therapeutic drug monitoring and hydroxychloroquine levels?
Well, I mean, there's more and more data gathering. I mean, and I think the takeaways I've taken from some of the work I've seen is probably the 6.5 milligram per kg dose gets closer to therapeutic levels. It gets closer to reducing flares. But the big thing about all the data on therapeutic drug monitoring is it just reveals how many people don't actually take their drugs.
Yes.
Actually, you know, the ones where, you know, they've got, and then someone's flat. And actually, how practical is this in a day-to-day working clinic? Like, you know, how often are we really going to use this unless it's a really tricky situation? I don't think it's nowhere near ready for prime time, David.
Absolutely. Well, yeah, I mean, even now, right, I think we know that adherence isn't great. If anything, we lean away from it in that, well, I don't know, the number of times you think, well, the patient should be due for a prescription refill. The primary care physician, the GP, is not writing the script for them. And I mean, this came to the fore in COVID, right? I think that you had the early, when we had shortages of hydroxychloroquine, to not be able, and patients who hadn't run out after a period of time is, hang on, you're meant to be on 400, you're meant to be on 400 milligrams. How come you still got supply? So I think, yeah, I mean, you're absolutely right. Adherence is still an issue, and probably more than this side.
All right. Well, maybe the next slide. Okay. So, yeah, this is real world data. This is something you can apply next week, and it reminds us, although we are inflammation doctors, that we have to think about cardiovascular disease and address risk factors. So this, there's two studies on this slide. One is in lupus and one is in rheumatoid. And the takeaway here really is these patients have a risk of major adverse cardiac events similar to people with diabetes. But perhaps there's something we can be doing about it. The first abstract looked at risk of major adverse cardiovascular event post non-cardiac surgery in people with lupus. It was a retrospective case study done in a US claims database where it used nearly 5,000 people with lupus undergoing surgery as the case, and the controls were people with diabetes and people who did not have diabetes. and they looked at incidence of MACE 1 and 3 months post non-cardiac surgery. Now one takeaway is it's not super common, less than 1%. So that's good. It's not a disaster here, but there's still a story to be told. So if we look at the table there, this is the outcomes, and these are people over the age of 18, MACE at 1 month, and this is a percentage with a confidence interval, just less than 1% for lupus and just over 1% for people with diabetes who are the controls, and no difference in the p-value there. But if you look at the next column over on the right, the non-diabetic controls 0.55, so 0.5%. So that's actually double incidence for people with lupus and controls at 1 month. And at 3 months, again, it's double the incidence, give or take, with the rate being up closer to 1.5% and quite significant there. Now, this was interesting because what they then did is did a multivariable model using the items of the revised cardiac risk index, which is a very standard clinical scoring tool used in the anaesthetic pre-assessment. And when they did a model using the revised cardiac risk index, the risk was attenuated, it went down. So what that suggests is that known cardiovascular risk factors are the likely mediators of the cardiac event in these people with lupus. So the takeaway there is we must make sure our anaesthetists know to fully assess cardiac risk, and we should be thinking well in advance of addressing cardiovascular risk factors in our patients with lupus, for all of them anytime, but particularly if they're heading towards joint surgery, bowel surgery, gynecological surgery, so managing risk. Now, the other study I just wanted to mention, Helen Keane brought this onto our attention, a 20-year follow-up. Geez, those people in the Netherlands are tenacious. They followed up 323 people with rheumatoid matched to people from general population and people with diabetes, and looked for cardiac events. And the cardiac event rate over that 20 years follow-up for people with rheumatoid was higher than the general population and similar to people with diabetes. So in that survival curve there of proportion of people without cardiovascular events, you can see the green is the reference cohort, and the overlapping blue and red lines, rheumatoid arthritis and diabetes, nothing between them, folks. So overall, over those 20 years, cardiovascular event rate for 35% for people with rheumatoid, 37% in diabetes, 26% for the general population. So, while not necessarily a completely new story, but a strong and stark reminder of the preventative healthcare work we need to be doing in conjunction with our primary care colleagues. So people going with for surgery with lupus, make sure they get a proper preoperative cardiac evaluation, and we need to keep working on cardiovascular risk factors.
So a bit alarming, Rebecca, that we've, despite all our advanced therapies and early intensive intervention and treat to target and all these awesome initiatives, actually that event rate hasn't changed. So highlighting, yeah, we now embrace cardiovascular disease. That's part of our remit. David, should we just tick that box every time we see the patient?
Yeah, I remember talking. So I mean, talking about those Amsterdam data, and that's Mike Noor Mohammed's group. I remember speaking to him a couple of years ago at ACR about what they did in practice in terms of screening in clinic. And you know what? Funnily enough, they find it hard to find time in a rheumatoid arthritis clinic visit, lupus clinic visit, to do the kind of things that we would ideally like to do in terms of that. And I guess maybe. We heard Helen talked obviously about, Helen told us as a group and asked us why, diabetic, with so many diabetic nurse practitioners support those patients. And whereas we don't have that same support, even though our patients are at similar types of risks, maybe that's the solution, that we probably need better systematic solutions to try and take care of our patients without necessarily dedicating more and more time, which already we're pushed for. I think that's my take on it. But I wonder, Rebecca, Andrew, whether that's something. Exactly. Yeah.
So one thing I do is even not just the first visit, but I try and aim to ask about smoking at least once a year. And I've audited my practice, and the rate of smoking in my patients is about 13%, which is very similar to a non-Māori population in New Zealand. The rate's higher in Māori and Pacific Islanders, but that's the average background rate. And I ask about smoking and use the ABC brief intervention. And I've had a few people give up, but the important thing is that I'm giving that message that this is important, and I'm going to spend 90 seconds talking with you about it. So when you go to your GP and they bring it up, you're getting a consistent message. There's quite a lot of literature that says that we are quite influential. There's a lot of literature that says that what a specialist says will be quite influential in behaviour change. The other thing I do, and I've got a little funny story about this, is I aim to take the blood pressure on every patient I see. It means we connect, I have to touch them, and when I've got medical students in clinic with me, I get the medical student to do it, which is very illustrative of who needs a bit more help and support. So it's just reinforcing to the patient that these are actually important things. The specialist thinks they're important too. I don't muck with lipids. I really leave that to the primary care. They are expert in that area, both from pharmacological therapy and dietary interventions. And I do look for the HbA1c. Has that been done? And yeah, so I think there are small things we can chip away at. I don't think we need to be so kind of fatalistic. It's not at all possible. You could choose one of those 5 things to do, and as we see them, twice a year, a few times a year, you can pick them up over time. And that just emphasises to them your cardiovascular health is important. I'm doing a bit of it today, but you need to get back to your GP. The number of times I pick up uncontrolled hypertension is kind of quite surprising.
No, I think that's absolutely true. I think we are embracing that as part of our in relation to the conditions and the medications. Now, before we move to the next slide, everybody, I should have mentioned earlier, please submit questions. There is a submit the chat box on the right-hand side of the screen, so please submit the questions there. And there's also the ability to download the presentation as well. So Rebecca, thank you.
Okay, so this is from Michelle Petrie, and I have a friend who during a fellowship went to Baltimore. You get some good stories when you live in Baltimore. She tells some good stories, both about Baltimore itself, but also some good stories about Michelle Petrie. Now, and Michelle Petrie is really an absolute meticulous at tracking and systematizing actually her lupus clinic. They have checklists of everything they need to go through. So she has approached this question of, hey doc, I don't want to get the vaccine because my disease will flare. I'm worried my disease will flare. And these data suggest that having COVID-19 or vaccination does not increase activity of lupus. So she has a prospective cohort at Johns Hopkins with nearly 1,000 people with lupus in it. And over the period of time that the COVID's been endemic in the US, Michelle's clinic has, Dr. Petrie's clinic has prospectively looked at this. And during the time that she collected these data, there were 65 patients who were PCR positive for COVID, who had 38 clinic visits where they were rigorously assessed for lupus flare, and there was no increased lupus activity in these patients, although there was an increase in anti-cardiolipin antibodies and lower rash scores. I don't think we can over-interpret that. There were 228 patients who'd had the SARS-CoV vax, who had 98 patients had clinic visits, and in those patients there was no change in lupus activity and no change in anti-cardiolipin antibody. So in this very well characterized cohort of patients with lupus, no evidence that COVID-19 infection or vaccination increases the activity of lupus. I guess if I had lupus, I would be quite worried about flares. I suspect that Dr. Petrie's clinic is a large amount of African American, probably women, who have perhaps more severe lupus than our day-to-day Australian, New Zealand lupus. So I can understand those patients might have a higher degree of concern. But this is a take-home message that those patients, we can reassure them that there's no evidence of COVID-19 or actually more realistically vaccination for us.
Rebecca, I'm a bit concerned about this data, I must say, and I know I've heard your how wonderful the clinic is and how, you know, tightly they're controlled, but I just don't. I've really got to challenge this data because that's not my experience, and I see a lot of people flaring. The 10% rate, maybe even higher. Had a lady who had a tamponade the other day who's ANA positive and some joint pains out of the blue 2 weeks after the COVID vaccine. So I think that we've got to put this in context, and David, I'm happy for you to chip in here, but I think we have to warn people they may flare. I think, you know, you said we're influential, Rebecca, we are influential, but we do need to put it, look, if they have flare and you say they're not going to flare, then that's a bad message. But I find this data difficult to understand.
Well, Andrew, I think at the end of the day is we want our patients protected. We don't want the fear of the flare to prevent them having the vaccination. So I'll offer you this. The evidence we have from this clinic showed that there was no increased activity of lupus. Yeah. However, you're a unique individual with your own disease, and I can completely understand that fear is a concern for you. Have a plan. If you get a flare, this is what you're going to do. You know, you make sure you've got that hotline, you've got the GP on board, and I will be there for you. But I want you to be protected. So I think we can, rather than dismissing this data, frame it in a way where we're actually aligning with the patient and addressing their fear and knowing, look, we think it's okay, but if you do fear, we've got you. You know, this is what's going to happen. So
that's good.
Yeah.
Very good.
Good.
Thank you.
So David, I'm going to hand back to you, my friend. I'm going to sit back and think what we can discuss between the slides.
Indeed. Well, and vasculitis is where, vasculitis, I think, has moved along from an era where we were watching a lot of observational data. We were you know, describing how things were going for ourselves without good therapies, and now we're in an era where we do have therapeutic options in small and large vessel vasculitis. I think it's quite exciting. And so hopefully we'll talk about, we'll select a few key abstracts, which I think are relevant to that. Let's talk small vessel vasculitis first, and I guess what we'll broadly call ANCA-associated vasculitis, but including EGPA as well. Does it matter what you use for induction? Now we know Ritux, Cyclo, there's a difference in toxicity, and that's not to diminish this. But the question is, we know from RAVE that the refractory group perhaps responded better to Rituximab induction rather than cyclophosphamide induction. Is this something that we see across the board in real world practice? Well, these are data at ACR that spoke to that. Firstly, in ANCA-associated vasculitis. So looking at this inception cohort, 550 patients, you know, a system that's not that dissimilar to us as far as ANCA-associated vasculitis is concerned in the US. And what we saw is, once you do all the propensity matching that you need to do to try and take these observational data and really compare two therapies which are probably prone to a little bit of channeling, a bit of confounding by indication, confounding by prognosis even. I think that once you take that down, we didn't see any difference between, in terms of the risk of end-stage renal failure or death, between Rituximab and Cyclo. So I think it's an important message. EGPA, and this was French data from Ben Terrier's a national collaborative that they've got there, phase 3, double-blinded randomized controlled trial, comparing patients with neurorelapsing EGPA between they were randomized to receive either Rituximab or Cyclo as induction. And I think everyone was expecting these EGPA patients, you know, anecdotally, they seem to respond well to Rituximab. Cyclo's a little bit of a blunt instrument. Won't Rituximab surely outshine Cyclo in these patients? Well, actually, if you look in practice, that's not what we saw. All relapse, and if you just look at the major relapse in your BVAS, you know, you can, like, if you're just looking at those things, if you look at those things between the two groups, you don't see a difference. Now, of course, that's not to say the tolerability is the same. And Rituximab obviously is going to become more accessible in the very near future in Australia, very likely to be unrestricted on the PBS, and certainly the prices have been plummeting with the onset of biosimilars. But I don't think we can say that Cyclo is worse than Ritux on the basis of therapeutic outcomes, and certainly Rituximab has its own drawbacks with COVID as well. So I think this has given me thought. I think I'd always maybe wrongly assumed that Rituximab was better than Cyclo, but the data from this ACR less so. I mean, I don't know what you've found in practice, Rebecca. Between the two of them, I guess in Australia we've used less and less Cyclo over time. Is it the same across the ditch?
Yeah, our prescribing restrictions are a little bit trickier. So cyclophosphamides are kind of the default, but over time I'm certainly using more and more Rituximab now it's available. I mean, I'm suspecting that many sort of jobbing rheumatologists, the numbers of patients they have with vasculitis, particularly in sort of general private practice, will be lower rather than high. Yeah, I mean, you're going to see some data a bit later on that does lead us to be a little bit cautious with Rituximab. If you'd asked me 2 years ago, I'd say, look, get rid of the Cyclo, it's Rituximab's day. But I've got to say, we're going to have to think a little bit more carefully about deploying Rituximab, at how, if we deploy it, and how we use it in relation to COVID-19. But that's just a little taster for what's coming.
Well, and it's good to talk about these things because we make these decisions, we make short-term decisions now, thinking about short-term risks, but there are long-term implications of the decisions we make now. Induction, ANCA-associated vasculitis, it's often a matter of life or death. To be in this situation, and there's usually a lot of stuff going on. It's stressful. You might not have many patients like this, but certainly, well, I'm glad we're having these conversations. I'm glad we've got you to talk about COVID later on, Rebecca, from the Global Rheumatology Alliance.
Yeah, thank you. Maybe next slide, David. I'm telling you, you're in charge, mate.
Next slide, I say. Next slide. Let's talk giant cell arteritis.
Oh, this is exciting. These are great data.
Well, I think giant cell arteritis, we've gone from an era where steroids obviously were the norm. Then we saw the exciting tocilizumab data. Not everyone's suitable for tocilizumab. Not everyone responds to tocilizumab. You still get refractory patients. You still get patients who, for whatever reason, have a contraindication to tocilizumab. And every now and then you have to go, you can't get any tocilizumab for love or money, and you have to go beg on the street like we have to do now. What do you do I had a colleague ask me about this today, because you can get some of these agents, you can't get tocilizumab. What do you do? Well, we've heard about plenty of other agents in recent ACRs, including mavrilimumab, which we saw some great translational data for at this ACR. But secukinumab is in the plenary for a reason. Phase 2 multi-center double-blinded RCT, the Titan study. Looking at secukinumab 300 versus placebo over a 26-week period, or 26-week taper, just like Giacta. Some slight differences between them, some debates about the way that the statistics are run with the Bayesian approach, but fundamentally, we saw pretty impressive data at the 28-week analysis, pretty impressive data at the 52-week analysis. That's what we're seeing here on this Kaplan-Meier. The big difference that we saw between the groups. Now, this is a kind of thing that, similar to what we saw, we've seen with other therapies, but I think to have the possibility of another option is particularly exciting. We're going to see a phase 3. The phase 3, I think, is about to start recruiting in the US, and that's exciting itself. Barry, I think so secukinumab, I think the interesting thing about that is the fact that plausibly, while IL-6 receptor inhibition might only just target that Th17 side of things, or certainly heavily favor that side, nothing to do with the Th1 side, the intravascular component. I think those are the questions that have always been raised about TOSI. So secukinumab, covering a bit of both sides. Barry, definitely covering a bit of both sides, and certainly giving you good coverage on the Th1 side of things, interferon gamma and the rest. So data from the Mayo, 15 patients in a prospective observational cohort which we've been anticipating for a while, but those patients did really well. Out of the 15 at 26 weeks, all in remission, 14 of the 15 in remission at 52 weeks. That's another thing to watch. We're going to see data from UPA come in the next year or two, which I think is going to be from a double-blinded randomized control trial, which will be really interesting as well. So bring on the phase 3s for giant cell arteritis. Lovely to have options. I know the two of you are both excited about these data, especially given that we can't get access to TOSI. What do you think?
Yeah, well, I mean, exciting, but you know how we're left behind on the other side of the ditch sometimes. So, well, you know, we catch up eventually. But look, it's just great to have new modes of action and new agents that we are familiar with. So I know, very exciting. But wait, on phase 3.
This was one of the standout, I must say, David, for me, this was one of the standout abstracts. Now, I'm tempted to, getting tocilizumab is not easy at the best of times, and we morph some patients into various conditions in order to get it. I might even morph them further in order to secure some secukinumab. It's like, how do you turn GCA into another condition? Well, I think if we think that's going to be the right thing to do, we should do it. But anyway, I think this is really, so far, a major step forward. And yes, we'll wait for the phase 3 study.
Yeah, absolutely.
So the only thing, just thinking back to last night, looking at the oral surveillance data, this is a different patient group. So these are older people, looking at that cardiovascular risk, which is, you know, the over 65s, the, you know, more than one risk factor. There was a bit of a signal there with the tofacitinib. So I guess that's the only drawback about the JAK inhibitor, you know, a different patient group being treated here. You know, there's quite a lot of 65-year-olds or 70-year-olds who have accumulated a cardiac event already. So, you know, so if I had to choose one of these to follow up, I'm more interested in secukinumab, I think, and also for infection.
Cardiovascular up again and again.
Well, I think the counterpoint to that is that potentially the big driver of cardiovascular disease and giant cell arteritis it's different to rheumatoid arthritis, and we're worried about Th1 inflammation driving. You know, we see coronary artery disease. I mean, so I think there are potentially different mechanisms of action to those rheumatoid arthritis patients. And I think importantly as well, we're talking about a time-limited approach. So potentially, we're not going to give Barry for life. We're going to give Barry for a year and then stop. Now, I don't think we can make any conclusions off the basis of 15 patients from the Mayo. I think we will see the double-blinded randomized control trials. We need to see phase 3 for all of them. But nevertheless, I think it will give people, oral surveillance clearly will give people pause for thought about Barry.
So a little tip, you only need to keep an eye out in the New England Journal, because if these are positive studies, that's where they'll be.
Sometimes the Lancet as well, you know, like the phase 2.
Well, no, I think New England would take these. So I'll reduce the scanning you have to do with the journals if these are positive trials. That's where they'll be.
Oh well, I think we've seen some interesting data on giant cell arteritis in many journals now, including in Lancet Rheumatology. And what we had seen was recently we saw the Gusto trial in Lancet Rheumatology. The Gusto trial, which we presented last year at this review, was from ACR last year. Looked at a much shorter steroid exposure with tocilizumab and giant cell arteritis. So instead of the 26 weeks that we saw in GIACTA, giving 3 pulses of a corticosteroid at the beginning of therapy, and then after that, not giving any steroid at all, IV toci, and then see what happens. Unfortunately, someone went blind in that small study. Some patients had ischemic events, and perhaps 3 pulses isn't enough. But we know at the same time, a lot of that risk is front-loaded. It happens in the first month or 2. And so if we give some steroids and cover things in those first 2 months, are we able to get away with less steroids and TOSI in GCA? And that's exactly what this open label study from MassGen looked at. And so as you can see there, 8 weeks of a taper of steroids, going from whatever you started at and protocolizing the taper down and continuing TOSI right throughout that. So some decent numbers out of it, and a lot of patients did well with this. But at the same time, you can see there you can see there 7 of the 27 relapsed, and some of these, while PMR symptoms maybe that's recoverable, scalp tenderness, jaw claudication, these are signs of ischemic, potentially ischemic complications. That's a lot more concerning. So I think you might be able to get away with less than 26 weeks, and I think a lot of people, including me, believe that. Whether 8 weeks is the answer or not, I think is still up for debate. In the patients that you've seen, Rebecca, with TOSI and giant cell arteritis, have you been disappointed that they're still on steroids?
Yeah, so no, David, we don't use that here.
Oh,
it's not funded in New Zealand. No, that's all right. I deal with this on a regular basis when I work with you guys. I just have to feel like the Cinderella in the therapeutic cellar.
Well, I'll say as well, we know that it's very, very likely that TOSI is underutilized in Australia. And the one thing that's worse than 26 weeks of steroids is several years of steroids when you don't use TOSI. And I think that's going to be still the factor in real life, trying to get some of these patients who aren't on a steroid-sparing agent onto a steroid-sparing agent in GCA.
So, David, my question to you is those clinical manifestations of relapse, do you think there are too many to justify this small prospective single arm going on to a full trial, or do you think that's kind of acceptable? Or do you think they'll come out with something else, the 12 weeks perhaps? You know, in humans, it's hard to do your dose ranging study, right?
Yeah, absolutely. I think that, we have not figured out how to use our steroid-sparing agents well. And basically, the numbers don't necessarily concern me. If there were 7 relapses and they were all PMR, and that's recoverable, as much as, I'll talk about as much as the next person about the impact of polymyalgia rheumatica. Having, if they were all recoverable manifestations, that would be perhaps less concerning. Keeping in mind that large vessel PMR can still be serious. Some of these ischemic episodes, I think, are what we're trying to avoid with steroids early in tocilizumab. And so that, in some ways, is not the only purpose of steroids in GCA, but it's one of the key purposes. So if you're getting essentially surrogates like jaw claudication of ischemic events, that gives me pause to say I don't think that this should continue through at an 8-week to continue through to phase 2 double-blinded RCT. Having said that, I'm sure that there are definitely people looking at shorter tapers, somewhere between 8 and 26 weeks. We'll find the sweet spot eventually, Rebecca. We'll find the sweet spot eventually.
Yeah, it would be wonderful to have a biomarker other than CRP. Something else we could use to decide when we can take the steroids down.
You get me in a beer and we can talk about biomarkers in GCA. But I mean, we saw data last year looking at that. We saw, and probably relevantly to this year's meeting, we saw data looking at mavrilimumab, that GM-CSF inhibitor. It's going through phase 3 in GCA right now, also with impressive phase 2 data. And what we saw was, in fact, that with mavrilimumab, you still get the signal for ESR and CRP with flares. And so we will start to see, and I suspect you'll probably see the same thing with secukinumab as well. So yeah. I will keep on moving. We're running. You and I are talking, and this is what happens. And we keep on talking along. We've got to get to COVID, and it's nearly 8:30. Tocilizumab and polymyalgia rheumatica. We don't have seen enough double-blinded RCTs positive done in PMR. We saw Rituximab presented last year, published this year, and this data is well and truly overdue. So these are data run out of Vienna, multi-center phase 2/3 double-blinded RCT, looking at tocilizumab in PMR. They used an 11-week taper. Given that polymyalgia rheumatica patients on your standard weaning protocol go out to 46 weeks on a wean, and many, the vast majority going far longer than that. What do we see if we can use TOSI as a steroid-sparing agent in these patients? Well, this is what you're seeing there. You can see big difference at 12 weeks, 16 weeks, 24 weeks, so well and truly after the steroids have stopped. You can see the difference there between the groups. I think there are some things to look at in this study which you can point at, and I don't think this is enough to go to a registration for tocilizumab and polymyalgia rheumatica. It's small. There are small numbers as well, but I think what we see here is enough of a proof of concept to see this pursued for PMR. And I know that we've got other therapeutic trials coming for PMR. I think we need to see more of this as well. Yeah, I mean, I guess, you know, PMR. You've got steroids in New Zealand, right? And you see these.
No, but the thing I'm thinking here is around the world they must be ramping up. Roche must be ramping up manufacturing of tocilizumab for the COVID market. So maybe Omicron will outcompete Delta and be benign, and COVID will disappear. And suddenly there'll be lots of tocilizumab. There'll be a fire sale, and maybe we'll be all washed with the stuff. So there might be some perverse outcomes like that. But certainly, I mean, polymyalgia rheumatica is the most frequent reason people over 65 are using long-term glucocorticoids. High burden of complications, fractures, skin thinning. No one likes being on steroids. And so to have another tool in the toolbox will be very exciting. I do wonder how this would fit into the standard treatment for polymyalgia rheumatica, because in New Zealand, PMR should be treated in primary care. You know, they don't come to rheumatologists unless there is something unusual or poor response to prednisone or inability to wean or some serious or sinister features. So our GPs are very well trained for a barn door. PMR will be managed very well in primary care. So I can't see tocilizumab being marketed directly to GPs for this indication. So we'll see. David, you seem surprised. Does most of the PMR make it through to all the rheumatologists? And
No, and I mean, I think we saw data, and I'm not surprised. In fact, it was a kind of a knowing smile, and we saw data at the study group at ACR. There's some Danes who are running trying to do a survey of primary care physicians around the world, but they looked at some of the Danish ones in the week before ACR, and they got them to nominate their starting prednisolone dose for polymyalgia rheumatica, which varied. I'd say 15 to 20, perhaps 25. That's certainly what the guidance says. Everything from 0 to 60, and a whole lot that was outside of that 15 to 25. I'd say most of it was outside of that. So I think I think we need to do better educating our GP colleagues, but at the same time, sometimes we have to seize the moment as far as polymyalgia is around.
Here's a Granger aphorism for you. 40 milligrams of.
I love this banter. We've got lots of red wine flowing. It's the Thursday night wind down. Rebecca's got the sherry, but I think we need to keep going on the.
All right, you're calling time. Okay.
Half an hour. So let's do it.
Well, I take that as a challenge, Andrew. You might wish you never said it. Next slide, David. COVID-19. It's the topic of the moment. So there were 2 systematic literature reviews published in abstract form at ACR Convergence 2021, which were trying to assimilate all the data on risk of COVID-19, of SARS-CoV-2 infection and COVID-19, and outcome risk of poor outcomes of COVID-19 in people with rheumatic disease. And the bottom line is probably increased risk of both. The first SLR is Conway et al., recently been published in Arthritis and Rheumatology, and the increased risk of infection was estimated an odds ratio of 1.53 and an increased risk of poor outcome of 1.74. Not insignificant. The other SLR was from an American group, a group in Texas, if I remember rightly. It looked like a poor resident put to work on this. And what struck me here is that the odds ratio it struck me and it didn't struck me. They pulled many of the same papers, but it's good to see an independent analysis came out with an odds ratio of 0.157, which is very similar to that 1.53. So very similar odds ratios for the risk of infection. They did a little bit more fancy things in the second study with drilling down into the different outcomes. And there was some differences between hospitalised and non-hospitalised patients, which might relate to the healthcare settings. But overall, the takeaway is even control, once remaining even after comorbidities and other risk factors are controlled for, people with rheumatic disease unfortunately do appear to have an increased risk of COVID and of poor outcomes if they're hospitalised. So we do need to be concerned about our patients, and I think the biggest takeaway is having those conversations about vaccination. So yeah, I don't think there's a lot more to say than that.
Yeah.
Yeah, and then the vaccination, this is the problem. So we do have a problem with immunosuppression attenuating the antibody response to vaccination. And this is the, I always get the emphasis around the wrong way, Covaripad, I always want to put it somewhere else, Covaripad study led by Al Kim, and a really big collaboration here. And they really they did a prospective observational cohort drilling down to the immunological response to the mRNA vaccines, 90% with a Pfizer vaccine, almost 300 people with chronic inflammatory disease, so they did include inflammatory bowel disease here, and 35 controls. You know, the take home is most of our patients make good levels of antibodies. That's the overall take home. But there are reductions in titer on some drugs. And I think the big ones in this group, it's still a small numbers with the B-cell depleting therapies with a reduction in titer of 58 and mycophenolate, a reduction of 21. And when I was reviewing these slides today, one of the things that just struck me is my patients, I've got a couple of patients on that combination, mycophenolate and rituximab, and they are the sickest patients I have, and they're the ones I'm most worried about having a poor response. So the takeaway here is the B-cell depleting therapies are one to worry about, and mycophenolate. The others are a small reduction, but we're getting the third vaccine in the primary series, so that should mop things up a little bit. We'll see that in a future slide. With the B-cell depleting therapies, the best responses were with a lot more than 6 months after the last dose, and there were data presented at the meeting that suggests that B-cell reconstitution is the predictor of response. So we're getting a clear message from lots of studies now, poor response, slightly reduced vaccine response, but particular concern about rituximab with careful timing of vaccination in relation to treatment. I mean, the one benefit is at least rituximab is an intermittent drug. You know, it's not a continuous drug. There is a window where we can vaccinate people many times. So David, have you got any comments about this at all?
No, I think you're right. And I mean, the B-cell depleting therapy being so kind of far away from everything else. I mean, it does strike, and I know that obviously it's some of this is trying to differentiate about perhaps the underlying disease versus and other factors that might be poorly prognostic versus the therapy itself. But there's good reasons why B-cell depleting therapy might be an issue for both the actual fighting COVID itself, and as well as dealing and actually giving a poor vaccination response. And to have these data quickly, having these data now.
I mean, we've just got to be so impressed with the rapidity which these research teams turn their energies to these questions. So, good slide. Andrew's. Yeah. Next slide. What have we got?
There we go.
More okay. Yeah, so more data that says the same story. A Swiss prospective cohort across 3 of our fairly common diseases, and there was on average, reduced antibody response after the SARS-CoV vaccination, and most of these were mRNA studies, but particularly, again, rituximab, so that same message coming through. A study from Quebec, which looked at the antibody response rate, which was pretty high across most of our diseases, certainly upwards of 80%, and improved after the second dose. but still those lower levels of protective antibodies in people treated with rituximab, only 10% in that cohort, but that will only be a small number of patients because out of those 220, not all of them will be on rituximab. So, that is an estimate only. It might be not as poor as that. That's certainly lower than some of the other figures, and mycophenolate, again, getting the same signal there. And in this small study from New York, the takeaway here was it's the B cell number that's predictive of the antibody response, and those those people represented by those circles down in that bottom corner where they've got a very low B cell count and they're not developing antibodies against the spike protein IgG antibodies. So it's the B cell number that predicts response. Now, I haven't seen any data yet where people are measuring B cell response and then deciding whether or not to vaccinate, but that is one thing that may come out in the future in terms of guiding timing of vaccines. So I don't think there's too much else. We'll move on to the next slide. So this is really, well, okay, we've been vaccinated. What's the risk of breakthrough after vaccination, and what's the impact of the third vaccine? So there's a case series of 88 patients from the Global Rheumatology Alliance registry. We added a question at one point about breakthrough infections once vaccination was becoming more frequent. In that case series of 88 patients, most had an mRNA vaccine. The time to infection was over 100 days, quite high rates of hospitalization. 5 of the 22 hospitalized died, and 10 of the 22 who were hospitalized were on rituximab. So you're just getting that signal again that, rituximab and COVID is not a good story to be telling. So then a much larger sort of population-based study using the N3C EMR cohort, which is a electronic medical record-based cohort, particularly collaborative put together to look at COVID and asking the question, are patients with autoimmune inflammatory rheumatic disease at higher risk than for breakthrough infections post COVID-19 vaccination? Large number of patients here, most getting the Pfizer vaccine, but some Moderna, and there was an increased risk of breakthrough infection with rheumatoid, with gout, curiously, with myositis and vasculitis, and also with our common medications, particularly of recent use. And that plot there does show the odds ratios across the different drug types, and you can see that many of them are slightly to the right. So, this is a real phenomenon of breakthrough infections in our patients. So what can we do about it? The third vaccine in the primary series. Now, this little beautiful coloured plot in the middle here is where the money is. They've taken patients, 60 patients on rituximab, and before the third dose, have looked, have they got an antibody response and have they got a T cell response? Now, this is really interesting because, theoretically, the T cell response should be independent of the B cell depletion. But actually, 30% of patients on rituximab had no antibodies response and no T cell response. So really no adaptive immunity response at all. And then 69% were antibody negative, but fortunately did have a T cell response. So then after the third dose of the vaccine in these 60 or so patients, you can see that patients in that red, no antibodies, no T cells, some of them, about half of them, moved up to have both. That's a particularly good news story, but many at least moved over to having a T cell response. And those patients that are left with no adaptive immunity protection is less than the 6%. So that's some actual biological data showing a distinct change in the underlying protection with that third dose. So the message is third dose.
That's what's happening. Sorry, go. Well, I was going to say that's what's happening in practice right now, isn't it? That we've got to advocate for these patients, really follow up the Ritux patients in particular to try and make sure that these we get shots into arms for the third primary dose, because this is a live issue. This is no longer an abstract concern. Andrew, you were going to say?
You know, we've stopped, I think I mentioned the other night, we've stopped people coming in, or tried to stop people coming in who are not double vaxxed. And this is one of those critical issues right here. You've got a patient with lupus on Rituximab or whatever sitting in the waiting room, and in comes somebody with COVID. You know, they could well be in trouble. We haven't quite instituted the QR code check-in at Suite 43, Cabrini Hospital, but it might not be a matter of time. But this is compelling data to say everybody get their vaccination. Even if you get the vaccination, you may still be in trouble. We don't want unvaccinated people contaminating our waiting rooms, staff, and other patients.
Yeah, it's a real live issue, isn't it? Right now, see what's happening in South Australia with it. Oh yeah, okay. There we go. My turn.
Oh, back to you, David.
To me, yeah, I'll stop on my South Australian anecdotes, and we'll talk a little bit about my favourite section, which is other. We've got some great abstracts here, and we'll run through them in the last 20 minutes. We've got Sjogren syndrome. What happens when this turns up in clinic, and how often do you follow these patients up? Well, I think that I struggle because get a lot of patients with Sjogren syndrome where you have very uneventful conversations where you talk about eye drops, you talk about oral lubricants, and then you're not sure what to do about lymphoma and how to screen this risk, and you can ask about B symptoms, but it's hard to know what that really means, and in fact that's not really going to be predicting the risks that we're concerned about until it's too late. How can we try and divide these patients up a little bit better? So this is work that's driven out of a group in Greece who have really been very good at starting to phenotype Sjogren's, and this is done over multiple different centres, which really starts to look at the generalisability of this all. And so these are patients, there are two abstracts combined here, but quadruple digit numbers of patients, and they've got genuine Sjogren's. So these are patients who meet ACR ULO criteria, so they either are Rho52 positive, or they have had a positive finding on minor salivary gland biopsy, as well as having other features as well. When you look at those patients, can you start to phenotype them? Well, you can, and you can see that there are some with eye involvement only, and those patients are at less risk of lymphoma. Those are patients with mouth kind of with xerostomia only, and you actually get a better sense of who they are as well. Lymphoma is not so much of a risk. The kind of patients we're worried about we should be worried about in terms of lymphoma are the patients who are leukopenic, patients with purpura, lymphadenopathy, who are Rho-LAR positive, and low C4. And those are all things which have been shown in other data to predict the risk of lymphoma in Sjogren's patients. And that's what we saw across multiple different cohorts here as well. So that's why I've got it in bold. And I think it's important. Certainly not most of our Sjogren's syndrome patients don't fall into that category, and we can relax, and we don't have to necessarily, maybe we don't have to follow them up forever. At the same time, some of these patients, you won't know if they've got a low C4 if you don't check. And some of these other things are a little bit more obvious. Those are the patients who are at risk of lymphoma. I don't know what you do in terms of follow-up of Sjogren's patients, Rebecca, and if you stratify them or how often you follow them up?
Yeah, well, I mean, they're not the patients we see most frequently. The person they probably need to see more frequently than me is their dentist or oral hygienist. I do examine for lymphadenopathy, and I don't know that I routinely order C4. But what strikes me about this is these are people who have some features of like active Sjogren's. So I think this is what it's telling us, is that active Sjogren's is correlated with lymphoma. I mean, for most of us, we'll go our whole practicing career and we'll never actually see a case of lymphoma in those small numbers of patients we have with Sjogren's. I guess they see it here because they've got this incredible cohort of nearly 1,800 patients across the 4 centres. But for most of us, but it's important to educate our patients and to examine them, because one of us is going to get someone, aren't we?
Absolutely. And when it happens, it's not, I mean, especially when that's the one thing that we're looking for on an ongoing basis with our Sjogren's patients.
But you know, the leukopenia I think is a useful one. And obviously the serology, yeah.
Okay, well, I'm definitely calling on you for a comment on this one, Professor Granger, as one of the authors, along with Lisa Stamp and Catherine Hill and some other friends. Omega-3 supplementation and serum urate and gout flares. And so this was a proof of concept study. I'll outline it, and then you can give your comment on how you felt about these data.
Sure.
This is trying to test this idea that maybe omega-3 supplementation might be something that might actually be able to influence gout. So I know certainly a lot of our gout patients would be amenable to that. So 40 patients, open label study, randomized to receive omega-3 fish oil and a decent dose from a decent producer, which I think is always a bit of an issue in these types of studies, trying to make sure that we get the right dose, versus no fish oil, 24 weeks, and then monitoring serum urate, monitoring flares, and it was, I think, a little bit disappointing that we didn't see a signal in that period of time, a signal of benefit in that period of time. I don't know whether this is the kind of thing where we needed to look further, or what the case was. I mean, Rebecca, did you? Yeah.
So I guess the biological driver is that could the omega-3 supplementation reduce the flares, actually, because that's a kind of non-toxic thing that people could take for a long period of time. And this was actually just a preliminary study. Can people actually take it? Do they put on weight when they're guzzling a bit of extra, albeit a small dose? So this is really more a sort of pilot study. But disappointingly, no difference in the flare number. But they didn't put on weight and no impact on the serum urate. So negative study, a good thing to explore, because our patients are so interested in what we think of as complementary and alternative therapy, but no signal here, unfortunately.
I sold my shares for vitamin D supplements. 30 years ago, I sold my shares for glucosamine. 20 years ago, I sold my shares for turmeric. 10 years ago, now I've got to sell my shares in omega-3. That looks,
yeah, well,
I'm disappointed. I haven't made a cent from this stuff.
So are you going to avoid buying shares in CBD oil then, or?
It's predicting. It's predicting.
That's the current, turmeric's off now. It's just CBD oil. It's
I missed that boat. Way missed that boat.
Yeah,
Thanks, David.
Yeah.
Well, I think it's vital that we have a look at some other data before you sell your shares. Vital study.
Could not resist.
It's always good to come up with a good name for your studies, right? Vital study. Unfortunately, we didn't come up with a name. Cardiologists did. The Cardiovascular study, looking at a 2x2 placebo-controlled crossover design RCT. So looking at 2 interventions, vitamin D, omega-3, and looking at a large group of largely North American people, and trying to see what happened in as far as the risk of developing incident autoimmune disease. And I think there's a lot sold about potentially vitamin D and fish oil preventing things. This was obviously, once again, to prevent cardiovascular disease. It didn't. Does it prevent autoimmune disease? Well, this is what we're seeing here, and the black lines are the reference line, and then these other broken lines in different colours are the combinations between them. And actually, even in a relatively short period of time, in a double-blinded randomized controlled trial manner, you're seeing potential benefit in there. Now, I mean, we've always thought maybe firstly, these are vitamin D replete people. We've always thought, well, maybe vitamin D is a surrogate for healthy living and generally taking care of yourself, and that's what stops you from getting autoimmune disease. Well, that's not necessarily relevant here. We've thought, well, maybe it's about being vitamin deplete, but that's not what we are, vitamin D deplete, but that's not what we're seeing here either. I think that, there are still questions about this. I would say that a substantial amount of the incident autoimmune disease here is autoimmune thyroid disease, and I think you can ask questions about how the criteria for that it was quite a low bar. How relevant is a lot of that? So not all autoimmune disease is equal. We as rheumatologists believe that. So I think that we would like to see further data. I'm not sure if we're going to see much in terms of that in a blinded type of way. But this does give pause for thought that maybe Andrew should not have sold his shares so quickly. because I'll tell you what's a bigger population than patients with gout. Patients who are worried about the possibility of future autoimmune disease. That's a big population you can sell to.
Sure.
I mean,
So David, what I didn't quite understand about this study is it's a 4x4 design, and so the people that get double placebo are the ones tracking up. But it didn't matter if you got active vitamin D or active fish oil or both; they all tracked along fairly similarly. So that's the one bit I don't understand. Like, what's the secret sauce here?
Absolutely. I think there's a lot to be done on that. And I think if you look at some of the other analyses, in fact, vitamin D and some of the other analyses probably did a little bit better than fish oil. It is a bit disappointing. There's seemingly no additive effect, not unless you kind of squint.
Yeah.
Where that green one might be a little bit less, but in reality, you can't say that.
No.
So I think it's interesting, right? Like, I think it does. I mean, especially when this kind of larger preventative type of approach, you do need really, big numbers. You can see here we're talking 25,000 patients in a study. It's not a cheap study to run. I don't know if we're going to get better data than this. So
the future study would be using a high risk population and targeting a particular immune disease. Because this is really a population with variable underlying risk and a whole lot of outcomes measured. So, but still, I guess if people wanted to ask the question, what should I take? Here's some data to say, if you're going to take something, this might. Oh, you got yours there, have you?
I took it out of the cupboard. I bought it several ACRs ago because you can't get this like 5,000 unit stuff here. So I bought the good stuff. Expiry October 2017. Anyway, never mind. I'm sure this is going to save me, right? This is going to save me.
But your non-compliance is impressive. Your lack of adherence is impressive, Dr. Lou.
You can still do a pill count on this. I think you can tell. Andrew, are you buying shares again? Yeah.
Oh no, I got a pack. I got the same packet, expired about 2009.
Sure. Okay. That's right. We've got 10 minutes left, and we've got some interesting abstracts still to go. Serious infections with biologics in utero exposure. I think we've heard a lot about sertolizumab not crossing the placenta. Good reasons why why perhaps we should be favouring it in that situation. But what are we worried about in terms of biologics crossing the placenta? I mean, one of the main things we're worried about is serious infections in baby. And so the question is that something we see with incidental exposure? US market scan data, so insurance data, and this is how you kind of get these types of exposures. And we're looking at quite a large number of patients, 16,000 patients. And these patients had to have one script filled in that period of time that aligned to their pregnancy. So look, there's some potential flaws with that, but at the same time, we don't see, these are not common things to get serious infections from in utero exposure in neonates. Secondly, we're really not seeing a signal there. TNF inhibitors, other biologics, ustekinumab, even other DMARDs, we're not seeing that as well. So at least as far as infection risk is concerned, I think we don't have to necessarily panic if we get some incidental exposure.
Yeah, so we're certainly not saying continue it to the end of pregnancy, but for those ones where there's a misunderstanding and they have not stopped, these data are reassuring to say, look, it's probably going to be okay. There's no evidence you've kind of actively caused harm.
Okay, I will keep on cracking. I think that's what Andrew's popped up to say. Keep on going, David. Keep on going.
Well, I was going to say, there was the German data a couple of ACRs ago that they just continued everything and it seemed to be okay. So I think our experience is a bit more continuing anti-TNF at least for the full program. But yes, there's certainly a possibility of stopping it in the last few weeks of pregnancy.
Oh, and dare I, wise rheumatologist told me once that it's about the art of medicine, and really it is about this selection of patients. Clearly, some of these patients, thinking about some of these IBD patients, we know there's serious pregnancy and maternal risks from active disease. we've just got to, but it's reassuring. It's just like those Canadian leflunomide exposure data, all very reassuring. I'm not saying that you necessarily do it. You've got to try and pick and choose some of your battles with this, I think. Okay, RNA pol 3. Well, this is the one that you don't get on the ENA, and you have to put specially on the sheet. And I think this is interesting data looking at Raynaud's phenomenon and how many of those patients progress to scleroderma. I mean, it reminds me of a patient I saw this afternoon where your patient's had Raynaud's, and the question is about what the risk of developing scleroderma is in these patients. Are there ways in which we can try and prognosticate this, knowing that potentially, A, we might be able to do more about scleroderma, and ideally we try and recognize it early, but B, that Raynaud's can be the first sign of scleroderma breaking forth. So this is data from Boston looking at RNA pol 3 patients, patients positive to RNA pol 3 who had Raynaud's, and then looking at the titer of the RNA pol 3. And so weak, moderate, strong. And what you can see here is that the titer actually correlates to the risk of developing scleroderma once you've got Raynaud's. And the stronger the titer, the stronger the association. So another thing to think about in this situation, not something that I don't know what people do normally for screening. I would, order an ANA and ENA, but I wouldn't have ordinarily put an RNA pol 3, but maybe this has changed the way I think about things.
So I guess this is asking, we get this in what we call an RNA blot test, a scleroderma blot test. And I guess a lot of our training, those tests didn't exist. So you were doing an ANA and deciding if this was primary Raynaud's with a negative ANA. And I guess this is just reminding us when the tests move forward, we need to decide what we're going to deploy them in. And this question of someone presenting with Raynaud's phenomenon is an important one. So I think potentially, I guess if you've made it through to a rheumatologist with Raynaud's phenomenon, there's something about you that the GP might be more concerned, because there must be a lot of people in primary care with Raynaud's phenomenon that may never make it to us. So that's an interesting thing to think about, who's the one seeing them and who's getting the test.
Absolutely. Well, there's good reasons now to think about actually trying to predict these patients, because we have an increasing number of therapies, and it's nice to have options. Once again, for a disease where we didn't have options not so long ago. We've seen TOSI data, plenty of TOSI data recently in scleroderma. What about Rituximab? Well, this is Japanese data, double-blinded RCT. And I'll cut to the chase here because I know I'm running low on time. You can see here, this is MRSS, and you can see placebo. We're not seeing pseudoloosening. This is these patients who are progressing in this double-blinded randomized controlled trial. And Rituximab actually led over the course of just 24 weeks to turning the ship around as far as that's concerned. So I think this is really encouraging. Still early data. And we will have all the provisos that we have for Rituximab, but at the same time, there's lung fibrosis is not great for your COVID outcomes either. So interesting data in our second to last slide. Yes.
Do you use much methotrexate in early systemic sclerosis? Because I wonder if it's do we need Rituximab? Could something else do the job? Is just worth wondering.
Well, I think it's about the magnitude in some of these patients, and these are patients who were at relatively high risk.
Certainly.
Yeah, look at the antibody profile there, 89% with diffuse ILD. So, potentially, I don't have as much luck as I'd like talking my interstitial lung disease colleagues into methotrexate in these patients, mycophenolate much more so when there's data on skin and lung, tocilizumab when I can buy it on the street corner. But I think, it speaks to the fact that we need options in these for these patients.
Yeah.
So
certainly a nice 4 weeks of treatment done.
Yeah, absolutely. Single hit with the ongoing risk, but single hit. And so we want to end this webinar on a high. We're going to talk about CBD.
Oh,
yeah, I know. Well, are you going to keep your shares or not? Well, this is a great question.
Yeah, no, I sold the shares. David, we'll try and do this fairly quickly.
All right, let's talk. I want to give you the is this going to be the last CBD trial that we need to do? Well, maybe, but we'll have plenty more. Plausibly, CBD, much more than dealing with inflammation, it has some plausibility in pain, hand osteoarthritis, inactive PSA with its destruction. We need therapies in this. The Danes ran a good study, sponsored independently, not by some manufacturer, but sponsored independently. Double-blinded RCT of synthetic CBD versus placebo. 136 patients. Let me give you the end point, the end outcomes here. So greater than 30% pain reduction, CBD 40%, placebo 40%. Greater than 50% pain reduction, CBD 25%, placebo 27%. You look down the outcomes, even in terms of opioid sparing, which is where this has all been thrown around, and this is not something where we saw benefit. Will there be people who do CBD studies after this? Yes. Does this give us something to talk to our patients about in terms of CBD therapy, and whether 2/3 of the way through the conversation, the clinic appointment, when they say they're on CBD, and do we think it's useful? I think this gives us something to talk about, especially when it comes to hand OA, something we don't have other good therapies for.
Thanks, David. Now, when this gets published in the New England Journal, Rebecca, I'm going to have it sitting on my desk showing people, yeah, no, I think I should have sold my shares a long time ago. Absolutely going nowhere. I would very much like to thank everybody for attending. I hope you found it useful, educational, and some pieces of information that you take back to the clinic that will be handy on a day-to-day basis.